Hello. I'd like to talk with you about drug allergies. I think this issue is relevant for pharmacists, nurses, and pharmacy technicians, as it's something that comes up with discussions with every patient we encounter. It's often misunderstood, or either the information is simply unclear. That said, after completing this program, I hope you'll be able to differentiate among true drug allergies, those predictable adverse drug reactions, and the non-allergic drug hypersensitivities. These are actually all different things. I also hope you'll be able to outline the different classifications of drug allergies. It's classified using something called the Gell and Coombs system, which we're going to explore, and we're going to emphasize the timing and clinical features which are used to distinguish drug allergies. I hope you'll be able to identify options for both acute and long-term management of drug allergies, and then describe elements of common drug allergies which we often encounter in clinical practice and what the implications are for patients and medical care. First, I think it's important for us to understand how it all fits together. It starts with understanding the adverse drug reaction. This is considered by the FDA any untoward or unintended medical occurrence that's associated with the use of a drug in humans. There are then predictable or type A reactions, or either unpredictable or type B reactions. Those that are predictable are dose dependent, and these are related to the known pharmacologic actions of the drug. These are going to occur in patients without any unique susceptibilities. They're nothing special. And they are going to make up really most of all adverse drug reactions out there, on the order of about 85 to 90% of what's encountered. These are things like your typical expected side effects, drug interactions, or just drug toxicity. The unpredictable or type B reactions are a little bit different. These are independent of the dose, and they're only going to occur in a small set of patients. And they have signs and symptoms that are actually different from what's expected pharmacologically with the drug. We can't predict these. These are going to comprise the rest of all the ADRs on the range of 10 to 15%. Then when you break down these unpredictable reactions, you get drug allergies or those non-allergic hypersensitivities. Of course, today we're going to talk about drug allergies, and I'll get into that next. But just so you understand also non-allergic hypersensitivities, these are also called pseudoallergies. And it's a reaction that often looks like a drug allergy, but it's not really the same thing. It's not mediated by the immune system. So that said, let's get into drug allergies. How do we really define one? Well, first, understand that it's unpredictable and it's immune mediated. It requires first contact with the drug in order to induce sensitization. Okay, so you have to have an allergen that may not necessarily be the parent drug you're administering, but even a metabolite once it gets into the body and is processed. But in any case, it accounts for 6 to 10% of the adverse drug reactions. And again, it's independent of the dose. There are several risk factors that are important. They can be patient-related or drug-related. I'd like to first share with you those that are patient-related. First is age. We know that reactions in youth are actually more likely to be transient. Essentially, you can outgrow them. Of course, there are some conflicting data about associations with age. This is confounded by patterns of drug use with various age groups. As you know, older adults are more likely to take more medications, so it's harder to really understand the distinctions between the groups. And we often seem to see more allergies in the elderly, perhaps because of that exposure, just a better opportunity to see them with more data. Women are actually shown to be more susceptible or more likely to develop an allergy than men. As for the mechanism of this, it's not quite clear yet. Then also comorbidities will play a role. Certain viral infections like HIV and Epstein-Barr virus, which tends to be more transient with susceptibility. Also cystic fibrosis and leukemia will factor in. Oftentimes with these, it's the fact that patients are being exposed more often to drugs like antibiotics, which do tend to induce that response and have higher frequencies of developing drug allergies in people. Immune status also plays a role. Previous drug reactions, needless to say, will factor in. If you had that reaction before, you're more likely to have it again. And then genetic predispositions. Genetic polymorphisms, like HLA polymorphism, which has been implicated in several more severe reactions, like Stevens-Johnson syndrome or toxic epidermal necrolysis, which we'll talk about later, have been implicated. And then there's also things like multiple drug allergy syndrome or atopy. Multiple drug allergy syndrome is kind of interesting. It describes patients with immunologic reactions to at least 2, but maybe more, chemically unrelated drugs. And then similarly, there's atopy. This is an inherited tendency to become sensitized to multiple allergens, which are usually proteins. So these patients will actually develop things like asthma or eczema, and even hay fever, and they're especially prone to food allergies. They don't necessarily have an increased risk for developing drug allergies, but they're just more prone to serious reactions. They tend to be a little allergic to everything. There are also several risk factors that are related to the drugs themselves. First is the drug's chemistry. Larger molecules are more likely to induce a response because these are more easily recognized by the immune system. They can be better detected. The smaller drugs, however, can then often bind with a carrier and form what's known as a hapten carrier complex, usually something like a protein. And then this complex is going to be recognized by the immune system because now it's a larger molecule. Biologic agents like proteins or drugs that are monoclonal antibodies, and even some chemotherapy drugs are also likely to elicit a response. So those are something to consider. The route of administration also plays a role. Topical agents tend to be very likely to cause drug allergies. And then parenteral agents over oral agents is the tendency there. Exposure is also important. Intermittent, repeated administration of a drug usually is the most associated with drug allergies. And then I'd like to say actually something about dose. Now, I did mention that a drug allergy can develop completely independent of the dose. Someone can have an allergy with just the smallest amount that normally wouldn't cause a problem in anyone. However, if the person has received a higher dose, because there is more in the body's system, you actually do have a greater risk in that sense. But again, I will say that even with the smallest amount, in theory, that could cause a reaction. It doesn't necessarily mean there's a threshold where a certain amount is required to induce the response. So once the drug is in the body, again, there is the initial exposure. Okay, so that's when the body is first sensitized. Then, let's say there's a second exposure. This is when you're going to get the allergic response because our adaptive immune response is what's activated. And this tends to be very fast when the drug enters the body because it essentially remembers this particular antigen now. And that's when things get into action. And you've got 2 branches of this system. You can either have an antibody-mediated response or a cell-mediated response. And it really depends on the drug as to which mechanism takes effect. In an antibody-mediated response, B cells kick in, and these are going to produce the antibodies after they encounter the antigen. And they can either form IgE or IgG. IgE antibodies are going to bind, and these are the kind that trigger the immediate response, like anaphylaxis. However, IgG are going to mark cells for damage or destruction, and they will produce a host of other symptoms. The other branch, besides antibodies, is a cell-mediated immune response. This is where T cells are activated. And then these are going to differentiate into other specific cells that are going to activate other cells, like macrophages. Oftentimes T cells are actually found in the skin, so this is where you're going to see those types of reactions like rashes. So just to quickly bring that all back together, understand that there's the first exposure to the drug, then there's a second exposure to the drug. Now we have an immune response that's been activated. You can either have a response through T-cell mediated activation or either antibody production. In either case, the ultimate result is the allergic response that's manifested in the patient. Now let's get into the actual classification of drug allergies. The Gell and Coombs system is what was actually developed to help us better understand drug allergies. And in the system, there are 4 basic types. You'll see in this chart the basics of each one, but we're going to go into each one with a little bit more detail through the rest of the presentation. You'll notice, though, that with type 1 reactions, this is the only one that's immediate in onset. It's IgE antibody mediated, just like I shared with you before. The rest are all delayed reactions, and these are mediated by either IgG antibodies or either T cells. These take a little bit more time to develop. And again, they're going to create a different array of symptoms in the patient. Most drug allergies do involve skin reactions, like rashes, which are typically those type 4 reactions you'll see at the bottom. They are pretty self-limited reactions, and they'll often resolve after you stop that particular drug. So that's a little bit of hope for most people. All right, let's start with the type 1 reaction. This is that immediate response. Usually it's going to occur within an hour of exposure, but it does depend on the route of administration. Like I said before, an IV drug is going to induce a faster response, as we understand with just basic kinetics. But of course, if you take it orally, that'll be a little bit slower, depending on whether you've got food on the stomach or not. In any case, IgE, it's an antibody-mediated response. IgE is going to induce the release of different mediators. The specifics aren't necessarily critical, but there are histamine and leukotrienes and even prostaglandins that kick in and cause the typical signs that we see with things like either anaphylaxis or similar severe responses. The histamine is often associated with the pruritus that's going to increase that capillary permeability and cause all that itching that we often see in patients. There's also bronchospasm, and this is usually caused by prostaglandins, actually, that are released. Leukotrienes are also involved in all of this and account for some of the hypotension, the flushing, and of course there's also angioedema that can be experienced in these kinds of reactions, and most seriously, anaphylaxis, which is going to require immediate attention for the well-being of the patient. Common drugs that we see associated with type 1 reactions include our Beta-Lactams, things like penicillin and the cephalosporins. Biologic agents, we've seen a lot with monoclonal antibodies and other protein-like agents, and then a lot of the platinum-containing chemo drugs. These are examples would be carboplatin or oxaliplatin. A quick understanding of what a type 2 reaction is. This one is IgG. That's going to bind to an antigen, and then it's going to target the cell for destruction. This one really isn't very common. It's only seen a handful of times. And because of the mechanism here, it's a delayed cytotoxic response. It's going to take around a week to induce the response after the patient receives the drug. A lot of cases, needless to say, are going to involve hematologic responses. You're going to see hemolytic anemia with things like beta-lactams or even NSAIDs. Thrombocytopenia has been seen with things like beta-lactams, again, heparin, and the anticonvulsant carbamazepine. Neutropenia or agranulocytosis has been seen with flecainide and propythiouracil. The symptoms can be often an issue where you need to look for, needless to say, laboratory values in many of these patients. But with hemolytic anemia, the patient may also present with dyspnea, fatigue, pallor, even jaundice, or they may have like a bounding pulse or roaring ears or palpitations. The thrombocytopenia, again, labs are very, very important as a diagnostic feature. They may have some petechial bleeding in their skin, or an enlarged spleen or liver. And with neutropenia or the agranulocytosis, it's really that severe increased risk of infection, depending on just how bad their labs are, and the labs themselves. Type 3 reactions are also IgG mediated, but it also involves the formation of a drug complex. This, again, is a delayed response. This can take up to 1 or even more weeks after exposure, so it can be a little bit longer than our type 2 reactions. And it takes a while to develop because you need that extra time to produce enough antibodies to generate the symptoms we actually see. Like the type 2 reactions, it also is quite uncommon. And the actual features that you see are a bit nebulous. A drug fever can sometimes be the only or the most prominent symptom of the allergy in this case, so it's really a bit ambiguous and difficult to detect. Drugs like sulfasalazine or even tacrolimus might be something that would cause this type of allergy. Serum sickness is another example of a type 3 reaction. With this, patients might get an itchy or red rash. They may have arthralgias. Beta-Lactams, again, and Bactrim have been associated with this one. Vasculitis is the third example of a type 3 reaction. And again, they may have petechia in the lower extremities. That fever may arise, arthralgias again, or even urticaria. And phenytoin and allopurinol are some examples of drugs that cause vasculitis as an allergy. Last, we have type 4 reactions. These work differently because they are T-cell mediated. This too is a delayed response, but it occurs within hours to days after exposure. This proliferation of the T-cells takes a little bit of time, so that's why we have that delayed response. And again, they are mostly found in the skin. The milder reactions are typically seen with our topical drugs. So you're going to see those skin eruptions and rashes and contact dermatitis. And so again, it's not surprising that we have the T cells mostly in the skin to induce this type of response. There are some severe reactions that need to be reviewed that can occur in a type 4 reaction. Stevens-Johnson syndrome and toxic epidermal necrolysis are types of exfoliative skin reactions that can be life-threatening, and these are often associated with a lot of anticonvulsants. And then drug-induced hypersensitivity syndrome is something else to be concerned about. So besides the topical agents and anticonvulsants, abacavir and dapsone or other drugs that might cause some type 4 reactions. Getting a little further into those severe skin responses, I'd like to share with you some information about Stevens-Johnson syndrome and toxic epidermal necrolysis. The way that we distinguish between the two is really about the degree of epidermal detachment. These are very severe reactions, as you can see even in the picture of this infant. They'll present with fever, and then the rest is all essentially a cutaneous response. You've got the lesions, necrosis, and then most severely the sloughing of the epidermis. In Stevens-Johnson syndrome, it's about less than 10% that you see of the actual detachment. If you have more than 30% of the sloughing of the skin, you're going to suspect toxic epidermal necrolysis. That the area of overlap between 10 and 30% would actually suggest an overlap of both symptoms. There's also drug-induced hypersensitivity syndrome. It's also known as DRESS. Signs and symptoms of this are similar to the other exfoliative reactions, including a fever and a maculopapular rash. However, the addition here is multi-organ system failure. So there's a little bit more systemic involvement. In both cases, these, like I said, have a high risk of mortality and infection, so they need to be treated immediately, and the offending drug should be stopped. Okay, so now we understand the basic reactions and how it happens. But how do we actually go about assessing a patient to decide if there really is a drug allergy at work, or if it's simply a side effect? The first thing you need to do is review the medical history, have a physical exam, and lab results. Now, I understand that, of course, it may not always be you that's doing this, but you should be able to hopefully review the information in the chart if possible. You'd like to know a detailed description of the actual reaction. You'll need to know the timing of the symptoms relative to when the different drugs were administered to help you discern what might be happening. You'll need to know if there was previous exposure to different agents. And then have a list of all the drugs that were taken at the time of the reaction. You'll also, of course, need a history of other drug reactions, allergies, and illnesses that might factor in to your assessment. You'll also need to consider other possible causes. Don't rule out things like an infection or another underlying condition, or even a non-drug-related contact dermatitis. Maybe they came in contact with poison ivy and didn't realize it. You also need to consider the drug itself. Remember, we talked about those drug-related factors that can contribute to drug allergies, and this is the time to consider those. Review the literature a little bit. Consider the presence of those drug-related risk factors, the chemistry, the route of administration, the type of exposure, and see how much information is out there about the prevalence of allergies with this drug. Now, after you look at all of that, you can say that a drug allergy is likely in a patient if the findings are actually consistent with an immune response. You can see a temporal relationship if the drug has actually been associated with immune reactions from your literature search, if the patient was previously exposed, because again, you need to have that initial exposure in order to induce sensitization, and you really just can't see any other cause. For skin tests, we have the options of intradermal skin testing and injections, or either patch testing, which I'll talk about next. In either case, the testing should be conducted in a controlled, monitored center because of any risk associated with reactions by the patient. Now, you can actually draw some markers for anaphylactic responses, like elevated tryptase, but this isn't commonly done, and it's a little unnecessary in a lot of cases. These are actually done to test for IgE-mediated reactions, so it's a little bit limited in who they can be used in. You also want to avoid intradermal injections in patients that are really high risk for anaphylaxis, not surprisingly. And then there are other high-risk patients that you would want to use caution in. People with poorly controlled asthma or reduced lung function who, if they have an actual severe response with the bronchospasm or difficulty breathing, it could be considerably difficult to treat. And of course, people with a history of severe reactions to minute amounts of other allergens could be especially susceptible. And then patients with cardiovascular disease might run into trouble too, and you would want to use exceptional caution here because if they get an anaphylactic response and have to be treated, some of the drugs that they may be on could counteract the agents you'd want to be using for anaphylaxis treatment. There are intradermal injections available for some things like penicillin and some of the biologic agents. Honestly, the options and the drugs out there are still really limited. You can get some protocols and some testing samples available for things like Beta-Lactams and a few other things like local anesthetics and others. But like I said, it's really limited. And unfortunately, skin tests are very drug specific. So you've got to use a dilution of the drug and inject it into the skin like you're going to place a PPD. But if you don't have the particular drug that's inducing the response, you're really not going to be able to tell if the patient has the allergy. For example, if they aren't allergic to the parent drug but a metabolite, you're not going to be able to detect a response because all of the agents used are usually the parent drug. So you're only going to catch a portion of a patient with an allergy. You can't necessarily rule it out. Whenever you do this, you don't, as an FYI, want to pre-medicate with something like an antihistamine or a steroid because it's just going to mask the response. You want to see it in full effect. And again, like I said, like, for example, with cardiovascular patients or anybody else that might be on something like a beta blocker, you want to hold that for 24 hours before the challenge because, like I said, it could interfere with treatment of something like anaphylaxis. So there's a couple of cautions there. When you interpret the results, there's basically you're looking for a positive wheal and flare response on the skin, and they are very predictive if you do get that kind of response. But negative results don't really rule it out. Like I said, it's got a high sensitivity, but really not the best specificity. A positive test, you're going to be able to tell a response within about 15 to 20 minutes, and the full-blown systemic reactions are really quite rare. However, the tests are going to come back negative if you do it too soon after an anaphylactic reaction, so you'll need to wait a while, or if they have actually taken an antihistamine drug, that could also produce a false negative. So there's some issues, or even like I said before, if the metabolite is actually the agent, that's causing the reaction, then maybe you've missed that because you don't have that particular allergen to test. They do sometimes do skin prick and puncture tests, but these are less sensitive and really not any more specific, so it doesn't help all that much. The other testing option for skin is patch testing. These are really reliable for assessing those type 4 topical cutaneous reactions. Basically, the drug is mixed in something like petrolatum or saline and just applied on the skin, covered up for about 2 days, and then they're going to remove the occlusion dressing and take a look. The same cautions apply as with the intradermal injections about, using antihistamines or beta blockers where you don't want to mask the response or interfere with any risk of anaphylaxis. But when you apply it, usually they test the upper back or deltoid area where you've got a clear space without any hairs to get in the way. And then usually to help avoid the risk of a false positive reading, the initial evaluation is going to be performed like 15 to 60 minutes after the patch is removed. So after you take it off, look at it within an hour, and then go back and do a second reading 2 to 4 days after the patch has been removed to look again and see what kind of reaction. Because again, there can be some variability in how long it takes for that type 4 reaction to kick in. Here too, there are just very few drugs that are commercially available to test. It's usually most effective for some of the anticonvulsants and a couple of antibiotics. There's also a graded challenge. This too will have to be done in a controlled monitored setting. And it's also known as test dosing. If you already know that someone has a positive skin test, don't do this. You could wind up inducing anaphylaxis, especially if it's IgE mediated. It's also contraindicated in patients that have had those severe exfoliative reactions or DRESS. If they've also had milder skin conditions with mucous membrane lesions, then you don't want to do it either. The protocols vary depending on the particular drug and the time course of the patient's reaction, but generally you want to leave time between the doses to make sure that the delayed symptoms that might be there have time to develop. But basically, you're going to administer the drug in a systemically in a graduated manner. So you give a little bit of the dose, and then you increase the dose a little bit later, and so on until you achieve the therapeutic dose you're trying to administer, and see at what point a response is induced. You'll want to include a few placebo doses as well. This will help exclude false positives or any subjective reactions from the patients. Again, don't pre-medicate with antihistamines or steroids. Hold those beta blockers. And be sure that patients who may have asthma or other pulmonary diseases have those symptoms under control. As an aside, for type 2 and type 3 reactions, which I didn't really address here in terms of testing, honestly, diagnostic testing is really limited to lab work, and there's nothing else we can really do to address that. The acute treatment options are really down to 3 choices. I will say that if the patient is actively experiencing a life-threatening reaction, you do want to treat this as soon as possible, as you obviously know, and discontinue that drug right away. Otherwise, the three choices are first to administer a completely unrelated drug. This is going to be a safe option, but it does carry the risk of other adverse reactions that the patient is exposed to. It could be more costly, or it could be less effective than the drug you originally wanted to use. For example, a lot of times I see in the hospital setting patients who have a penicillin allergy, so physicians will often prescribe vancomycin intravenous instead, and of course this has a whole nother host of concerns like renal toxicity, and it can be more expensive, and it's a much broader coverage drug, so you would then look into the issue of antibiotic resistance and so on. So it gets a little messy. You also have the option to give the patient a similar but not identical drug. Now here you have the risk of cross-reactivity, but this is going to vary depending on the class of the drug and the severity of the reaction. Another example here, again, if the patient has something like a penicillin allergy, maybe give them a cephalosporin. We'll get into that a little more. You could also undergo a desensitization protocol to that particular drug, but this is indicated really when there's not any alternative to be used, because this is very involved. Okay, so what is the drug desensitization process? A lot of times it's also called induction of drug tolerance, but most commonly we call it drug desensitization. It modifies the patient's response just temporarily. This is short term, just for the interim. So you can give that drug that one particular course of therapy. It's used for IgE-mediated reactions or your non-allergic hypersensitivities, which remember I also called those pseudoallergies. Once the patient stops taking the drug, or if there's an interruption in therapy, you're going to have to start all over again. The way it works is that the drugs are administered in small doses, and then you give progressively higher doses until you reach that full therapeutic dose. And then once it's been the patient's been desensitized, you go ahead and just give the drug like you normally would to any other patient. Now, in this process, they might experience some mild symptoms during that protocol, and if that's the case, maybe just pause administration and offer maybe symptomatic treatment, and then carry on once that's resolved. If you give them too big of a dose increase, you might get breakthrough allergic symptoms, so be aware of that. You can give the drug by oral route, IV route, or sub-Q route, but the way that you desensitize doesn't necessarily have to be the same as your therapeutic route. Like the graded challenge, this should rarely be performed if the reaction is probably a severe non-IgE mediated, with those severe exfoliative reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis. But know that it is also safe in patients of all ages or even pregnant patients. Like the other actual testing options, you still want to hold beta blockers if you can and if it's clinically appropriate. And be sure that those patients with lung conditions, again, have symptoms under control, just in case the anaphylaxis happens anyways. If the patient happens to experience hypotension, laryngeal edema, or becomes unresponsive to epinephrine, if you have to use that, you just want to abort the protocol and try another option. It's also helpful to know some long-term management techniques for both patients and providers. First, the option to tell patients is really to avoid the culprit drug. You also need to know that those with severe drug allergies may even consider having a wallet card or an ID bracelet, so that one, they can remember, and two, that if they happen to take a drug or a similar agent, someone who encounters them or finds them, or a paramedic even, if it's a severe response, will be able to understand perhaps what's going on. You can also educate patients about avoiding potentially cross-reactive ones so that they can be proactive in communicating with their providers. You also want to minimize exposure to drugs in general, which is a good rule of thumb for everyone. Really, only take drugs when you need to. You want to limit antibiotic use, which are, your common culprits, and limit, your own exposure to infection in general. Stay away from sick people if you can. And start any new drugs cautiously, especially in those folks who have atopy or multiple drug allergies. You may even have to start patients at lower than normal doses or take meds under a little bit closer observation. I'd like to go over a few of those commonly implicated drugs that we often see in clinical practice, because it might help you better understand what's really going on and distinguish between the real allergy and potential pseudoallergies and how we really need to handle these. I will say that regarding the issue of cross-reactivity within these classes, package inserts might not always contain the most up-to-date information. And of course, this is the info that enters into a lot of databases that you may use to check things or may pop in for alerts for you when you're reviewing information. And this is quite unfortunate, especially for the older drugs that are out there, because there's a lot of new research that's going to refute a lot of the old cross-reactivity concerns that were out there, and it might not be incorporated into the revisions of the prescribing information, so those misconceptions are perpetuated. First up, let's discuss the infamous Beta-Lactam allergy. So the Beta-Lactams include penicillins, cephalosporins, carbapenems like meropenem, and then aztreonam, which is a monobactam. These are a really highly reactive group. It's a very large molecule, and it is the most commonly reported drug allergy among patients. Roughly 10% of people actually report it. But when you do skin tests, lo and behold, only 10 to 20% of them really have a positive skin test. They are less likely to have a serious reaction as the time since the last exposure increases. So this is one of those instances where age plays a role, and a lot of times folks will say, oh, I had a reaction, or someone told me I had a reaction when I was 5, but now I'm 50, and so I don't know anymore. So there's a good chance that perhaps they're no longer actually allergic to penicillins. The greatest cross-reactivity is between your penicillins and the first generation cephalosporins and carbapenems. As for the general concern for cross-reactivity, though, between the penicillins and the group of cephalosporins as a whole is really quite low. It's only 1 to 2% or even less. In the past, there were concerns that it might have been much, much higher. It's really much, much less than we thought, and so those agents like cephalosporins can be used more safely than we thought. So when we're going to manage a beta-lactam allergy, recognize first that all 4 of those reactions are possible, so we have to take the right approach. If they have a type 1 IgE-mediated reaction, it's going to happen immediately, and you need to simply avoid the drug if possible. But if necessary, go with a desensitization protocol. In the picture, you can see a severe penicillin reaction. This is courtesy of the CDC Public Health Image Library. Obviously, beta-lactam wasn't a good choice for this patient, and an alternative therapy was necessary. But in milder reactions, like skin reactions seen in the photograph, you have the options of treating with a structurally unrelated antibiotic altogether, or just treat with a different beta-lactam. Like I said, that cross-reactivity might not be as high as we once thought. Some people even suggest that with those severe or IgE-mediated type 1 reactions with a penicillin, those folks might be able to take a 2nd, 3rd, or 4th generation cephalosporin. Remember, the cross-reactivity is highest with the 1st generation ones, so still avoid those. I will say that there's no actual risk of cross-reactivity with aztreonam, unless that patient is allergic to ceftazidime, because it does have the similar chemical structure. All right, into the sulfonamides. There are 3 classes of sulfonamides based on their chemical structure. You've got the sulfi antibiotics and protease inhibitors in one class, loop diuretics and sulfonylureas like your glipizide and glyburide in another, and then another category of miscellaneous agents. Here, type 3 and 4 reactions are the most common, but occasionally you get the type 1. Sulfa antibiotics are by far the most common within the sulfonamide groups to cause allergies. About 3% of the population has an allergy to sulfa antibiotics, and you usually end up with a rash and often with fever. So this will be either a type 3 or type 4 reaction that'll appear within 1 to 2 weeks after exposure to the drug. And I will say, too, that sulfonamides are chemically unrelated to sulfur, sulfates, and sulfites, so they don't cross-react. So if a patient is allergic to Bactrim, they are not allergic to morphine, at least not necessarily. There's no cross-reactivity. Now let's talk about NSAIDs and aspirin. For a true allergy, you can have a type 1 reaction to a particular agent. True allergies make up about 30% of all of the hypersensitivities with this class. The type 1 reactions can be divided into two groups. You can either have an anaphylactic response or just urticaria and angioedema. Every once in a while you'll get a type 2 response like thrombocytopenia. But like I said, that's pretty rare. Most commonly, the response or an allergic response is seen with ibuprofen, but all in the class are potential allergens. Unfortunately, there isn't any skin test available, so once you know the particular drug that is the allergen, you just simply want to avoid it, and you can treat with other NSAIDs that don't cross-react. You can find information on the categories and breakdown of actual classes among the NSAIDs and choose one that's safer for the patient. And there have never been any confirmed cases of anaphylaxis to aspirin itself. So in that sense, you've got some flexibility there. Then, of course, there is a pseudoallergy to NSAIDs and aspirin, and this is actually more common. There are 4 different types, and they all are a response to the inhibition of COX-1. So in the body, again, you're going to get something that looks like a type 1 reaction, but again, it's a pseudoallergy. Your management options are limited to 2 choices. You can simply avoid the drugs as a whole, because people here are not going to react to just one drug like they would in the case of a true allergy, but they're going to react to the entire group of NSAIDs. You have the other choice of giving them Tylenol if in doses of below 650 milligrams, because this drug is just a weak COX-1 inhibitor, so it's less likely to cause that. Once you get into higher doses, you increase that risk, though, of inducing the pseudoallergy. Or you can give them a COX-2 selective inhibitor. Drugs like Celebrex would be appropriate. Then let's talk about opioid analgesics. Again, we have a true allergy and the much more common pseudoallergy. The true allergy can come in the form of a type 1 reaction, which is IgE mediated, or the T-cell mediated type 4 cutaneous reaction. The common symptoms in either case include hives and rashes. The management options are usually to use a non-opioid analgesic like Tylenol or NSAIDs. Or if it's a true allergy, you want to choose an opioid from another structural class. You can see that there are 3 different classes, and most fall into the morphine group. So if their allergy is there, you may have more limited options. You could try a graded challenge with a drug in these cases, but monitor closely. Know that tramadol is okay for your milder reactions, but if they did have a severe reaction, you want to be more cautious. Of course, the opioid analgesics can more commonly cause a pseudoallergy, which is induced by the histamine response by the immune system. This will cause the itching, flushing, sweating that people commonly complain of with these agents. You want to reduce the dose when possible. That will cut down on the severity of the reaction to a more tolerable level. You could provide symptomatic relief with antihistamines. Or actually try a more potent opioid, because these are the ones that are less likely to release histamine. You can see in the graphic the potency of the opioids in the class. I don't have coding on here, but know that that is less potent than all of these. So that's why people often, I think, say that they're allergic to it, because it is most likely to cause all of that itching that they say. But it's just a pseudoallergy. Or actually, not even that, a true reaction, or a drug reaction. Anticonvulsants often come into clinical practice, and these are implicated in types 2, 3, and 4 reactions. These are a bit more nebulous. They may be linked to abnormalities in metabolism in the body, reactivation of latent herpes virus, or even genetic predisposition. A little more research is still happening there. You have to retreat with an alternative agent altogether. You can see there with phenytoin can cause vasculitis, carbamazepine can cause thrombocytopenia, and then both agents, along with phenobarbital, can cause those severe cutaneous reactions. Okay, most reactions to vaccines are going to be the immediate IgE-mediated, or type 1 reactions, and the symptoms may involve the skin or the respiratory tract or the cardiovascular system. You can have some delayed reactions, so at least be on the lookout for these, but they're less common. The live attenuated or the intranasal vaccine for influenza is contraindicated in people with an egg allergy, and this, especially if they have anaphylaxis, it's especially risky for them. Yellow fever, however, can be used cautiously if the reaction to eggs is not anaphylaxis. It's safe if the reactions were milder. The vaccine contains some egg and chicken proteins, but it also has gelatin, and so the reactions haven't been extensively investigated, so they do say to use with caution. The measles, mumps, rubella vaccine is actually considered safe. The research into the previous concerns showed that the reactions weren't actually caused by the egg allergens, but to gelatin, which was the stabilizer in the vaccine. So as of 2011, patients with influenza or with egg allergies can take influenza vaccine, and again, the MMR is the safe one. Of course, patients can be allergic to other vaccines because of additives besides egg proteins, so just be advised to be on the lookout for that. And warn patients as well that they need to be aware of those as well, as a lot of those components can be in multiple agents. There are a few miscellaneous allergies. Radiocontrast media, like anaphylaxis, can cause anaphylaxis or urticaria or angioedema or even skin reactions. It's most commonly associated with IV administration, and the reactions are distinct from the typical side effects that can occur, like renal toxicity. Seafood or shellfish that kind of allergy is not actually a risk factor. This is a common misconception, though. I think it's more an issue of atopy. So rule that out and don't assume that the person is actually allergic to the radiocontrast media as well. Peanut allergies often persist into adulthood, whereas children with soy allergies may often outgrow them. The older CFC inhalers, which have essentially been phased out, did contain soy lecithin, and these weren't safe for people with soy allergies, but the newer ones, the Atrovent HFA and the Combivent Respimat, are safe to use. There are a few drugs that contain peanut oil, so be aware of those. Another pseudoallergy worth considering is the infamous ACE inhibitors. Angiotensin-converting enzyme inhibitors. These are lisinopril, ramipril, enalapril, and so on. These are the most common cause of drug-related angioedema. By design, ACE inhibitors break down bradykinin, which causes blood vessels to dilate. In the case of folks who experience angioedema, the bradykinin builds up and can't be inactivated, and that causes the angioedema. For them, the risk is always present, but there's a circumstance, for one reason or another, that triggers the reaction. It doesn't occur all the time, but when it does, it's severe. So it can occur years after they started taking the drug. It's not necessarily instantaneous. And interestingly, patients can usually tolerate the angiotensin receptor blockers like Cozar or Benicar. Vancomycin can also cause a pseudoallergy. Red man syndrome with flushing and itching of the upper body can occur as fast as 5 to 10 minutes after you start an IV infusion. Prevent it by slowing the IV infusion rate or giving an antihistamine, since the histamine response or release is what causes the response in patients. There's also reactions, pseudoallergies to local anesthetics. The reactions vary from the psychomotor effects of anxiety-related symptoms like hyperventilation to vasovagal syncope to tachycardia and hypertension to systemic toxic effects like CNS stimulation in people who are really sensitive. It might be induced by something like rapid absorption, high doses, or even an accidental IV administration, again, versus a true allergy. So what's the bottom line? Please just clarify allergies to drugs whenever possible. Recognize that not every drug reaction is really necessarily an allergy. With a little bit of extra awareness, we can really figure this out. We need to document them appropriately, because when we have inaccurate or incomplete records of those so-called allergies, we get into a lot of trouble. We might end up with unnecessary avoidance of drugs, we're going to complicate patient care, and then we just perpetuate misconceptions among providers and also patients. Just don't be shy about re-examining allergies that were previously documented. Update the list and get the real story. However, if the reaction was ever anaphylaxis, or even looked like it, it's probably safest and simplest to just avoid the drug. Now, of course, if you can actually categorize it as a true allergy, additional measures could be taken to provide adequate therapy, or even desensitize the patient if the drug's absolutely necessary. But please, don't be afraid to take a closer look.